Good morning and good afternoon. My name is Tamil Kendall, and I am the Director of the Partnership for Women's Health Research Canada, or POWER. To begin, I would like to respectfully acknowledge that I am on the traditional unceded territories of the Coquitlam, the Musqueam, the Tsleil-Waututh, and the Squamish First Nations in British Columbia. And as we're joining from coast to coast to coast today, I would like to invite you to take a moment to appreciate and acknowledge the traditional territory that you're joining from today. POWER is an alliance between the Women's Health Research Institutes from across the country. The Women's Health Research Institute in British Columbia at BC Women's Hospital, the Women and Children's Health Research Institute in Alberta, the Women's College Research Institute at Women's College Hospital in Toronto, Ontario, and IWK Health in the Maritimes, as well as the Women's Health Research Cluster, which is located in BC, but has international reach. And we are supported by the BC Women's Health Foundation, the Alberta Women's Health Foundation, the Women's College Hospital Foundation, and the IWK Foundation in moving towards achieving our mission. And part of achieving this mission is to promote a national conversation about the health of women, trans, and non-binary people, and how research can inform and accelerate improvements in policy and practice. All of you who are attending today are a very important part of creating and expanding this conversation. So please, as we go along, use the Q&A function that's on your screen in order to share your thoughts with me and the panelists, and we'll pick this up in the discussion that will follow the presentations. The theme of our 2022-2023 Women's Health Research Seminar is knowledge mobilization. And today we are going to hear from our panelists about two research initiatives, one to improve sexual assault services, particularly for trans individuals, and another to promote sexual health among new parents. These initiatives are different in terms of their scope and reach. The first is a provincial collaboration that has spanned almost 25 years and reached hundreds of service providers working on gender-based violence. And the second is a newer knowledge sharing initiative on sexuality being led out of Dr. Rosen's research lab. Both have important lessons to teach us as researchers and as service providers about successfully engaging with those who are providing direct services to design research that transforms practice and the services that are received. Overcoming stigma and discrimination related to gender and sexuality and promoting gender equity in social services, and the contribution that women's health research can make to improving these health and social services seems particularly pertinent to me as we recognize the week of trans awareness and the Day of Remembrance that is just passed and move towards the 16 days of activism against gender-based violence that begins on Friday, November 25th. In this context, I'm honored to invite Ms. Jenna Sudds, the Member of Parliament for Kanata Carleton and the Parliamentary Secretary to the Minister of Women and Gender Equality and Youth, to make opening remarks. Parliamentary Secretary Sudds, the floor is yours. Please go ahead.
Thank you so much, and such a great pleasure to be with you today. As mentioned, my name is Jenna Sudds, and I have the distinct honor of being the Parliamentary Secretary to the Minister for Women and Gender Equality and Youth. Some really incredible work that we get to do day in and day out. I want to start by acknowledging as well that I am speaking to you from the traditional unceded territory of the Algonquin Nation. And I'm pleased to connect with all of you from the various territories and communities that you are in today. So I welcome this discussion and this opportunity today to meet with you, members who I know play a pivotal role in improving the health and healthcare of women and their families. I know that you perform a vital public service by encouraging excellence and innovation in the research that you do. So I'm here to talk to you a bit today about the importance of this work in addressing the challenges confronting the 2S LGBTQI+ communities. These communities, as I'm sure you all know, have been subjected to homophobia, transphobia, biphobia, and other forms of discrimination and oppression for far, far too long. Just this past weekend, we witnessed yet another example of hate against 2S LGBTQI+ communities with the deadly shooting in the Q nightclub in Colorado. And I want to express my deepest sympathies to the victims and the survivors. Well, of course, this is not happening in Canada. It is still very close to home. And I know that the impact on our communities certainly needs to be acknowledged. So we are well aware that there is discrimination and bias in many of our foundational sectors, whether that be in health, employment, or in the housing market. And the obstacles are even greater for the 2S LGBTQI+ communities, experiencing additional marginalization, such as Indigenous, Black, and racialized communities, and people with disabilities. Since 2017, the Government of Canada has taken historic action to build a better, more inclusive future for 2S LGBTQI+ communities and for all Canadians. We passed legislation that provides Canadians with explicit protection from discrimination, hate speech, and hate crimes based on gender identity or expression. We expunged and destroyed criminal records for people convicted of consensual sexual activity with same-sex partners. We banned so-called conversion therapy, a cruel, harmful, and degrading practice that has caused lasting pain and trauma for Canadians from the 2S LGBTQI+ communities. Health Canada recently approved Canadian Blood Services submission to stop the blood donor deferral period for men who have sex with men. We also established the first federal 2S LGBTQI+ secretariat that works with stakeholders across the country and helps inform the government on issues and potential solutions that are important to 2S LGBTQI+ people in Canada. Nous faisons également des organismes qui servent et qui défendent les intérêts des personnes for persons 2S LGBTQ+ in Canada. For example, budget 2019 earmarked $20 million for the LGBTQ2 Community Capacity Fund to support 76 eligible projects to strengthen organizations that are dedicated to supporting the well-being of the community. And then in budget 2021, we invested an additional $15 million for a LGBTQ2 project fund to support community-informed projects, ranging from addressing harmful practices and policies to enhancing knowledge and tools, to changing norms, attitudes, and behaviors. And in August of this year, the federal 2S LGBTQI+ action plan was launched. The action plan itself presents a suite of new measures to advance rights and equality for 2S LGBTQI+ communities and people in Canada, and address and prevent discrimination and stigma. These include capacity building and project focused supports for community organizations who have their finger on the pulse, as well as new data collection that will inform future initiatives. Le plan d'action fera avancer les initiatives visant à favoriser l'inclusion et à éliminer la discrimination au moyen d'une campagne nationale de sensibilisation. The 2SLGBTQI+ action plan was developed with input from frontline community workers, researchers, and civil society organizations. It also was informed by the findings of the 2SLGBTQI+ action plan national survey, where more than 25,000 2SLGBTQI+ people responded to the survey, shared their lived experiences related to safety, health, housing, and homelessness, employment, discrimination, as well as stigma and resilience. We learned through that survey, for example, that 39% of 2SLGBTQI+ respondents reported experiencing violence directed at their sexual orientation, gender identity, or gender expression in the last 5 years. We discovered too that respondents identifying as asexual, non-binary, or gender diverse were most likely to report that healthcare professionals were not very or not at all knowledgeable about how their sexual orientation, gender identity, or gender expression impacted their health needs. While we know much more today than we did 5 years or a decade ago, there is still a long way to go in improving our understanding of the realities and challenges 2SLGBTQI+ people face in Canada. And that's why people like yourselves, that's how you can make a major contribution. Organizations like yours can help to fill the many knowledge gaps that remain on 2SLGBTQI+ communities in relation to access to safety and justice, employment, workplace inclusion and discrimination, as well as health, stigma, and resilience, especially among those that are the most marginalized. As included and indicated in our 2SLGBTQI+ action plan, the Government of Canada will provide up to $7.7 million to conduct new data collection and research activities that will build on existing research and evidence building activities and inform future initiatives. Ending stigma and discrimination and achieving Canada's diverse equality goals requires the input and support of many essential players, especially research leaders, people who can explore what more we can and must do to achieve a future where everyone in Canada is truly free to be who they are and to love who they love. There will always be a need to have up-to-date information to inform policy and program delivery. So the Government of Canada's 2SLGBTQI+ communities are hoping that we can count on you to bring your intellectual curiosity and innovative ideas to this shared national task. Working with the spirit of sensitivity and respect, we can all put our skills and our knowledge to work to build a safer and more resilient community. Together, we can advance this vital work to ensuring that the rights of and equality for 2SLGBTQI+ people in Canada, I very much look forward to working with you as we do so. Thank you very much.
Many thanks, Parliamentary Secretary Sudds. It's been a great pleasure, and I'm so glad that you'll be with us to hear about this groundbreaking research, both to promote the health of women writ large and also of trans and non-binary communities, including LGBTQSI communities across Canada. And thank you so much for providing that overview of the investments and really important legislative changes that the federal government have moved forward. And also a big congratulations on the passage and agreement by all the provinces and territories on the National Action Plan on Gender-Based Violence, which is also a very exciting step forward for the country. So thank you very much. And now it's my great pleasure to invite Dr. Janice Mont, senior scientist with the Women's College Research Institute and professor at the Dalla Lana School of Public Health at the University of Toronto, and Sheila McDonald, provincial director of the Ontario Network of Sexual Assault and Domestic Violence Care and Treatment Centres, to make their presentation. Janice and Sheila, the floor is yours. Welcome to you.
Thank you.
Janice, my dear friend, there you go.
Okay, sorry about that. Of course, I forgot to turn on my mic. I apologize. Thank you for the warm welcome, Tamil. It's a real pleasure to be here. Before we get started on our presentation, I just want to recognize that our work takes place on the traditional Indigenous territories across Ontario. Sheila and I also wish to acknowledge that Women's College Hospital is located on the traditional Indigenous territories of the Huron-Wendat, Haudenosaunee, and the territory of the Mississaugas of the Credit First Nations. Today, the meeting place of Toronto is still the home to many Indigenous people from across Turtle Island, and we're really grateful to have the opportunity to work and present in this territory. So I've been conducting various types of research over the past 25 years, but the research I've really found like most meaningful and impactful is being conducted in partnership with the Ontario Network of Sexual Assault and Domestic Violence Treatment Centres and their associated service providers. Sheila McDonald, whom you just learned is the director of the network, will start this presentation by describing our decades-long partnership, our integrated knowledge translation approach, and some examples of how this approach has been used in the past research and work to impact policy practice and outreach. And then I'll come back and I'm going to focus more specifically on how this work laid the foundation for our current research, which is focused specifically on enhancing services for trans and gender diverse survivors of sexual assault.
Yes, hi everyone. So as introduced, I'm Sheila McDonald. Just to give you an idea of the who we are and the work we do. The Network of Sexual Assault Domestic Violence Treatment Centres provides support, leadership, education to 37 hospital-based programs across the province that serve both urban and rural areas. We provide the acute, which is up to 12 days, and non-acute, typically up to 30 days, care to victims of sexual assault and domestic violence, all persons across the lifespan. In terms of services provided, the clinicians, our teams are staffed primarily by specialized trained forensic nurses or at times nurse physician teams who provide crisis intervention, medical assessment and treatment, testing and prophylactic treatment for pregnancy and sexually transmitted infections, including HIV, collecting forensic evidence, documenting the assault history and any injuries, risk assessment and safety planning, referrals to our follow-up services we provide and counseling, and then referrals to various community agencies for other types of support, such as housing. So as Janice had said, we have collaborated on research for some time. Our program of research is founded on an integrated knowledge translation approach. The central premise, which is to involve knowledge users as equal partners alongside researchers, leading to research that is more relevant and more likely to be useful to the knowledge users, our clinicians. But our knowledge user partners have, in our work, have included more than the service providers from the network. We've also included NGOs, government decision makers, clients of our services that have been involved in each stage of the research process, from the idea formation through to the dissemination of findings. We've used iterative IKT process to guide our research. So first identifying the problem or concern within the clinical setting. And then together we've proceeded to review whatever evidence is available, design a study or program of care, implement the study, evaluate the outcomes, and then share the findings broadly, and develop, implement, and monitor what has often become a new standard of care. So this approach and the methodology has led to advancements in policy, optimization of care provided to diverse survivors of gender-based violence, and tools to reach out to survivors, families, the public, and other health and social service providers, among others. So the following slides will give two examples of what we've done. In the first example, the drug-facilitated sexual assault study, this happened because frontline nurses identified a rise in sexual assault cases where there were increasing reports of drugging, so the victim wasn't aware that they had that the drugging had occurred. But there was a lack of a systemized response to victim survivors. There was also limited access, for example, to lab facilities to test these samples that for the range of drugs that we were looking for, and at trace levels, which is also necessary. And the Center of Forensic Sciences that tests biological samples do not test samples if the police are not involved. So that was also an issue. So the study was undertaken to develop a better approach for care for victim survivors of DFSA. And to do that, 7 treatment centers around the province representing the socio-demographic, cultural, and geographical diversity of the province participated. As well, there were other knowledge users. So we had an advisory committee comprised of forensic toxicology, forensic biologists, sexual assault physician, that offered expert opinion and advice at various stages of the study, including how to define drug-facilitated sexual assault, advising on the measurement and testing of the samples that we were collecting, and aiding in the development and implementation of the study protocol, guidelines, forms, etc. Further, we had a community reference group that acted as a resource to the principal investigators. And so they reviewed the study protocol and guidelines and offered feedback. So we had police services, Crown Attorney, victim assistance, Secretariat, the Ministry of the Attorney General, the Coalition of Rape Crisis Centers, and client consumers representatives. So the findings of the study were supported by ECHO, a former provincial agency that released a policy and action brief, which recommended to the Ministry of Health, our funder, that a new standard of DFSA care be implemented at all treatment centers in the province. The findings also had a direct impact on practice, with the developed, documentation was integrated into our protocols. A new DFSA training module was developed and integrated into our sexual assault nurse examiner training program. So that's the middle. document you can see there. We developed a brochure for first responders, including the police. We were also able to develop a protocol for access to toxicology testing across the province without needing to have the police involved, which was important for our survivors to have access to that. We also collaborated in developing KT outreach tools that included a video targeting youth, law enforcement, emergency service providers, healthcare providers, the public, and policymakers. A poster targeting potential bystanders, that's the black poster on the right you see, infographics and pamphlets for survivors and families and friends. The second example is the elder abuse project. So again, we sort of, I think, enhanced or expanded our collaborative efforts, but it started with frontline providers coming forward, concerned that there was no standardized training for the care of abused older adults at the centers that covered the range of abuse, such as neglect, emotional, financial maltreatment. And so a needs assessment survey that was done showed that over 94% identified that this was an important need for us. So the goal of the resulting project was to enhance the care provided at Ontario's SADVTCs to abused older adults. An in-person training was developed from the needs assessment. There was a systematic review of available evidence and series of Delphi consensus surveys and piloted with a cohort of SADV nurses in 2018, I think it was. Our diverse team of knowledge users also include government decision makers in health and social services, such as Employment and Social Development Canada, advocacy organizations representing the interests of older adults, such as the Advocacy Center for the Elderly, older adults, so potential consumers of healthcare services, community leaders working in social service, finance, interfaith, emergency service, law enforcement, and legal sector, so public trustee and guardian, for example, and other health service providers, such as occupational therapy. Once evaluated and to increase the reach, the in-person curriculum was redeveloped into an online format and launched in 2019. An evaluation of the learning showed that it improved knowledge and skills. Since the release, the e-learning curriculum has become standardized training available for all SADV nurses across the province, with more than 500 learners to date. So information about the training has been shared widely through infographics on social media and websites, printed and distributed info cards, YouTube videos, etc., which has created a lot of interest from forensic nurse examiners internationally that would also like to complete the training.
So thanks, Sheila. I'm going to build on some of the strong foundation of collaboration that was established through the DFSA and elder abuse studies Sheila just spoke about, and other studies that we don't have time to cover today. We shifted our focus, and again, this was based on a new issue brought forward by SADVTC clinicians to the need to improve the response to transgender and gender diverse sexual assault survivors. And here I just want to stop for a minute and say, based on the input of our trans collaborators, we use the term trans as an umbrella term that actually includes anyone who's not cisgender. For example, non-binary, two-spirit, gender diverse, gender queer, and gender fluid folks. However, we do recognize that language is very important and always evolving. So it's critical to note also that in the context of this particular work, the invaluable knowledge, insights, and lived experiences of trans communities have been included at every stage, and often in the context of their capacity themselves as being service providers. So in order to enhance the response to trans sexual assault survivors, we first developed, implemented, and evaluated a series of curricula. We worked with an advisory group of trans community members and their allies that included, this isn't a totally inclusive list, but Rainbow Health Ontario, AGEL Canada, the 519, to establish trans affirming, care competencies for nurses working across Ontario's SADVTCs. In a province-wide survey we conducted, 100% of SADVTC program leaders agreed that there was a need for trans-specific training for SADVTC nurses. Trans-affirming care competencies then became the framework for an in-person training for SADVTC nurses, and the process is described very well in a video that I'm just going to show now.
Trans populations experience disproportionately high rates of sexual victimization, have historically faced discrimination by healthcare providers, and may have unique and diverse needs post-victimization. In Ontario, a quarter of trans people seeking care at a hospital emergency department have been ridiculed, and 1 in 5 trans persons avoided emergency departments because of previous discrimination or fear of experiencing discrimination. A 2017 survey across Ontario's 35 hospital-based violence treatment centres, which provide comprehensive healthcare, psychosocial, medical, and forensic examination services for sexual assault survivors, found that 96% of specially trained forensic nurses strongly agreed that there was a need for training in the care of trans survivors of sexual assault. To address this gap, Women's College Research Institute and the Ontario Network of Sexual Assault and Domestic Violence Treatment Centres, in collaboration with Rainbow Health Ontario, a province-wide program aimed at improving the health of LGBT persons in Ontario, have been developing a novel curriculum for sexual assault nurse examiners in the care of trans persons who have been sexually assaulted. With funding from the Women's Exchange 15K Challenge, a specialized curriculum entitled Providing Trans-Affirming Care for Sexual Assault Survivors was developed. The curriculum drew on skills-based competencies that were adapted from recommendations in the U.S. Department of Justice National Protocol for Sexual Assault Medical Forensic Examinations and endorsed by Forge, a transgender anti-violence advocacy group. The curriculum's 31 competencies were finalized by an advisory group of trans community members and their allies who subsequently aided in the development of the curriculum. The curriculum includes a training manual, training module, and facilitator's guide that includes case studies and interactive discussion components to facilitate learning. The curriculum was successfully piloted and evaluated on November 21st, 2018, with 47 nurses during the biannual sexual assault nurse examiner training for frontline nursing staff. Quantitative data collected from pre- and post-test questionnaires showed that although almost a quarter of participants indicated that they had provided direct clinical care to a trans client in the past, over 70% of participants indicated that they had not undergone any prior training on providing care for trans clients. After the training, participants reported on average a significant increase in their overall perceived level of expertise in trans-affirming post-sexual assault care. Participant scores on competence improved significantly across all domains of the curriculum: initial assessment, medical care, forensic examination, and discharge and referral. Qualitative feedback revealed that participants recognized the significance of this training. One participant indicated, "This training is incredibly relevant and important. This should be available and mandatory for healthcare providers everywhere."
So since the pilot and successful evaluation of the in-person training, it's been adapted to an e-learning format, rolled out to all SADVTC nurses across the province, successfully evaluated, and has since become one of the standardized trainings. We also spent some time on the e-learning further adapting it and making it more relevant to other health and social service providers. And we were able to launch that adapted curriculum recently. We've been really pleased with the uptake of it. A lot of diverse institutions and organizations have asked for both our in-person and e-learning curricula. Just some recent ones to highlight: Indigenous Services Canada, the Canadian Armed Forces, the Yukon government, and then we were really surprised also when we heard from the United States Navy recently asking to use the curriculum. So next we began work on building an intersectoral network on trans-affirming practice. Trans survivors often require supports beyond those provided within the healthcare sector. And in the survey that we had conducted that I mentioned earlier, nearly all SADVTC nurses working within Ontario's SADVTCs indicated a strong need for knowing how to better refer, connect, and consult with trans-positive resources and service providers in the community. In order to address this need, we began working with many other trans-positive service provider knowledge users across the province. Some of them are represented on this slide and the following slide as well. We then connected with experts from health and social services in the community and working within SADVTCs in 7 regional meetings. These were held in summer 2019. Luckily, we weren't in the midst of a pandemic at that point. We visited 7 cities to host these: Toronto, Mississauga, North York, London, Ottawa, Sudbury, and Thunder Bay. And really the purpose of the meetings was to determine the interest of these organizations and working together moving forward. And we really arranged these meetings on the fly, but we're very pleased that 106 representatives attended from 96 distinct organizations. And what we found at these meetings was that attendees overwhelmingly agreed that forming an intersectoral network could enhance supports for trans sexual assault survivors. They felt that it would support service providers in becoming trained to provide trans-affirming care. It would create a space for organizations to share goals, ideas, and resources, provide a platform, strategies, and tools to aid in organizational change, and mobilize advocacy efforts by centering the voices and expertise of trans communities. So we then set about to establishing a network, to determining a sense of shared ownership among potential members. We developed and circulated what we called a network formation survey. It was focused on developing the network's potential identity, including activities, deliverables, mission, vision, and values, the latter of which you can actually see on the slide here on the right. We also documented and developed strategies for addressing barriers to collaboration. One of the really interesting findings to arise from that survey was an identified need for information related to providing trans-affirming care. So beyond a curriculum or curricula, which we had already developed, we therefore created and circulated a survey to network members to gather data on the availability, also accessibility, trustworthiness of online information related to the care and support of trans survivors, as well as we really wanted to know the importance of various resources and features that they might like to see on some kind of website or web portal. And based on the insights from that survey in March 2021, we launched the TransLink Network web portal. And you can see some images from on the slide here. You know, the web portal has a really wide array of content. If you're interested in gender-based violence, particularly within the, you know, the as it impacts trans persons, and the care providers are able to provide, then, you know, visit the website. But it includes guidelines. There's an interactive membership directory. It's being used by service providers and trans survivors to locate and access appropriate services in their region as well. It's working as a referral tool. There's also a hard copy of that directory which can be downloaded. It contains information also on joining the network. And I think currently we have about 140 some odd members. We also developed and implemented transformative knowledge. This was a social media campaign to promote awareness among providers about the damaging attitudes, beliefs, and reactions that often impede trans survivors' access to appropriate services. We work very closely with Trans Wellness Ontario on this particular project. Based on insights from findings from focus group with trans community members and health and social service professionals, we designed 7 posters. We circulated these on Twitter over about a 5-week period. And the campaign reached approximately 100,000 Twitter users during that time period, with almost 2,000 engagements. And all of those posters are available on the web portal. And then really recently, we did an evaluation of the network, really a baseline evaluation, because the network is still quite new. We found that there were 378 unique dyadic collaborations among the 119 member organizations that were providing direct service. And, you know, really this demonstrates considerable engagement among partners. And these collaborations were directly related to supporting sexual assault survivors who were trans. Overall, the network achieved high scores for value and trust. much higher than some other evaluated networks that you will find papers about published in the academic literature. And high value and trust is also indicative of the potential for more integrative, intensive, and expansive work, as well as long-term sustainability of the network. I'm just going to talk a minute about challenges and lessons learned related to this work. So I'm thinking about the work and the collaboration with service providers and the IKT process more generally in terms of all of the research that we've talked about today. So not surprisingly, we have found that there are challenges, but we've tried to be very proactive in developing strategies to address them, and I'll just highlight a few. In working collaboratively with many partners, it can be really challenging to maintain high quality relationships. But we did find that regional in-person meetings and keeping the lines of communication open through multiple different channels has been valuable in not just in deepening connections, but in better accommodating the regional needs of organizations. And to ensure meaningful engagement of service provider collaborators, that's been another challenge we've encountered. We have, for example, most recently begun to work from a working group approach, with each working group participating service providers and other knowledge users from the communities having their own terms of reference, and those working groups are meant to align very well with the overall goals of the studies, but also the members' expertise. And then maybe just finally, over the course, of many of these multi-year collaborations covered in this presentation, there's been a lot of changes in leadership within partnering organizations, shifts in workload, and with respect to the TransLink Network project specifically, some related to the COVID-19 pandemic itself. So we've, again, developed standardized processes for onboarding new leaders. We've worked to maintain open dialogue about capacity with regular check-ins. During the pandemic, we were able to pivot to remote work while maintaining meaningful collaboration and connection by following best practices and community-engaged research during crises. This included, task sharing, knowledge exchange, and we provided centralized support for virtual activities. So those were some of the things that we found were helpful. And then this is my final slide related to the work. Overall, despite the challenges, and again, we're always trying to learn from those and be proactive, we think that the integrated KT approach to research has led to some considerable enhancements to policy and practices related to responding to sexual assault and intimate partner violence. So the collaborative work that Sheila and I have done, and many of the other collaborators with us that we've talked about, it's increased the relevance and use of research, and in the SADVTC context specifically, it's led to documented and concrete improvements in services. It's ensured that the full range of survivors' psychosocial, forensic, and medical needs are being assessed and appropriately addressed. It's engaged, empowered, and supported service providers in enhancing care. And I think this is very important. We often sort of forget this. It's built research capacity among service providers within and beyond the community organizations that we've worked with. So thank you for listening. We're indebted, of course, to frontline sexual assault nurses, program leaders, trans communities and their allies, sexual assault and domestic violence survivors, and many, many other collaborators from across sectors who've helped make the research studies presented here possible. I want to finish with a quote from Dr. Bud Hall, formerly of OISE at the University of Toronto, but he has a prestigious, just going to get the name of it right, a prestigious UNESCO chair in community-based research and social responsibility in higher education. And many years ago, he said, and it still resonates, knowledge that is created locally in the world of practice is cutting edge. The larger questions of life are being addressed in daily practice, not in the academy. And I'm going to end there.
Many thanks to you, Janice, and also to Sheila for that very inspiring presentation. And I love that last quote from Bud Hall, and certainly know from my own experience, particularly as a community-based HIV researcher, that this is true. Often the innovation, even in clinical treatment, the innovation that led to pre-exposure prophylaxis, that's something that came out of community practices and their understanding of the function of antiretroviral treatments. So I can't agree with Bud Hall more that the innovation about what's needed in life and to improve the health and well-being of the communities that we serve really comes from those communities. So thank you very much, and we'll come back to discuss more in the moderated discussion with you. But now I'd like to invite Dr. Natalie Rosen to join us. Dr. Rosen is a professor in the departments of psychology and neurosciences and obstetrics and gynecology at Dalhousie University. Her research focuses on understanding how individuals and couples cope with sexual dysfunction and changes in their sexual lives and relationships, such as the transition to parenthood, which we'll hear about today. Welcome, Natalie.
Thank you very much. Can I just confirm that you can see my slides okay and hear me okay?
Yes, we can.
Okay, great. Thank you. Thanks for the invitation to have me come and share some of my work today about a campaign called #PostBabyHankyPanky. I'm joining you today from Dalhousie University, which is located in Mi'kma'ki. In Mi'kma'ki, there were two treaties called the Peace and Friendship Treaties signed in the 1700s, which were negotiated between the British Crown and the Mi'kmaq Nation. And this agreement did not include ceding their lands. So this means that the Mi'kmaq still own the land that I'm living on and speaking to you from today. And what is especially important about the treaties that I really think is important to highlight is that they're about the relationships between people, how to treat each other, how to coexist, and that Indigenous peoples were to have the right to control their day-to-day lives. I'd also like to recognize the histories, contributions, and legacies of the African Nova Scotian people, who are one of the oldest and established African Canadian communities who have been here for over 400 years. Finally, the research that I'm sharing with you today was conducted within a North American context. So this is important to keep in mind that it may not generalize to other populations. So I want to start out with why we saw a need for this project. So probably not a surprise to many people in the audience that there is a lot going on during the transition to parenthood. It's clearly a time of a lot of joy, excitement, and happiness for many people. And it has a huge number of new stressors like fatigue and changing body image, changing roles and identities, and less time together as a couple. And all of these together have consequences for the sexual and romantic relationship of the couple. In fact, we see that compared to community couples who are not in sort of this transitional period, new parent couples report lower sexual desire, lower sexual satisfaction, higher sexual distress, that's worries and concerns about their sexual relationship, across 3, 6, 9, and 12 months postpartum. However, these group differences start to become a bit less pronounced by 12 months postpartum. But what is particularly interesting is that by 6 months postpartum, there's no longer any differences in terms of their sexual frequency between the postpartum couples and the control or the community couples. So these effects don't seem to be explained by new parent couples having less sex. There's other things going on here. These disruptions to the disruptions in low sexual well-being has some important consequences. We know it's linked with, of course, general health, increased healthcare services utilization, postpartum depression, more relationship conflict, and even less sensitive parenting. The tricky thing is that most expectant and new parents report that they receive very little information about these potential changes to their sexuality and their sexual relationship. So this is some data from our own recent online survey, where we found that the vast majority reported receiving little to no information about changes to their sexuality during this time, either in pregnancy or postpartum. However, when they did report receiving more relative to less information, this was linked to greater sexual well-being for both members of the couple. So this brings us to this campaign, because it was really that gap in knowledge, that gap between, we know that there's these problems, people don't really receive any information about them or how to manage them. And that was kind of some of the gap that we wanted to try and fill with this campaign. So this is a knowledge sharing campaign with this fun little hashtag, post-baby hanky-panky. Post-baby hanky-panky. So our overarching goal was to share some of the evidence-based knowledge about factors that we learned about in our research that promote sexual and relationship satisfaction during this transition to parenthood, and with the idea of stimulating interest and communication about this topic in a sort of engaging way. So we weren't necessarily trying to change people's behavior with this campaign. We were trying to reduce some of the stigma and sort of discomfort that people had around talking about this issue, with the idea that that might lead to accessing additional resources as needed or support. How, and I'm going to tell you more about the how for the whole rest of the presentation, but the end result was that we developed, disseminated, and evaluated a series of YouTube videos for social media based on our previously conducted research findings. We followed a particular planning process for this project using a knowledge translation or KT planning tool. So if this sparks your interest and you want to learn more, I highly recommend you check out the knowledge translation tools developed by Melanie Barwick and her team. The website is at the bottom of the link for this slide. And there you can have access essentially for free to these planning templates. So when I started out in this area, I didn't really know what I was doing or how to do it. And it was extremely helpful to have this sort of model that is evidence-based that I could follow. So I'm not going to go through all of the steps. There are 13, which I don't have enough time to go into sort of detail with you this afternoon, but I wanted you to get a sense of what it looked like. So the first 4 steps are up on the screen, and it's things like just walking you through, who's going to benefit from the evidence. So who do we need as partners? That's step 1 there. Partner engagement. So when is this going to happen? In our case, at this time, unlike the talk you just heard, which was an integrated approach, we had already done the research. So this was an end of grant sort of time point. What are the roles of the people involved? What kind of expertise do we need, and so forth. The final step in that 13th step in that KT planning is your specific procedures that you're going to follow. So in our case, it was started with doing the research. Then we received a grant from Research Nova Scotia to do this project. We convened an advisory board, and I'm going to tell you a little bit more about that in a minute. And through those conversations and with the advisory board, we made the decision to develop these videos. We then hired a production company to make the videos. We developed our evaluation plan. We sort of did the project, disseminated and rolled it out, implemented the plan, and then had an ongoing evaluation. So the advisory board was a really key part of this project and its success. So in our board, it included partnerships with several different sort of types of people and organizations. So we looked at we had a family doctor, we had 2 obstetrician gynecologists, a midwife. We partnered with Reproductive Care Nova Scotia, whose mandate is to support new parents during this transition. We wanted an expert in knowledge translation because this was my first project in this area. So partnered with an academic who has done a lot of work in that area, Christine Chambers. We also partnered with a parenting blogger who was a social media expert as well. We had 3 parents on our advisory board, and then of course the researchers. So I wanted to talk for a minute now about sort of some considerations when thinking about these partnerships and putting together an advisory board. So when thinking about who you want to consult with, it's important to consider who your target audience is, and then including representatives from all of these groups. Also, who has access to your target audience, so who has a sort of like wide reach to get to those people, and importantly, who has expertise that you might be lacking. So that was that example I gave about the both the knowledge translation expertise at the time and also social media expertise, because we were thinking of using that as our dissemination strategy. So how do we engage and how do we approach and engage these different partners? So I had a few thoughts here to share with you. So one is that it's okay to start with your own network and ask for recommendations from knowledgeable people. So at this point, I had an established relationship and an appointment in obstetrics and gynecology. So I approached them first and asked, who sees a high volume of expectant parents? I asked for recommendations for family doctor and midwife who might be interested in sort of partnering in this work. So it's okay to use your network. We also use social media to get our parent partners. So we posted advertisements about that we were looking for people to get involved. And we also draw on our participants from the research themselves. So part of the consent forms for all of the research that I conduct now actually has a section of the consent form around interest in partnering for knowledge translation activities. So we had a huge, list of people, and we had many, many more people interested than we kind of had room for that we could go back to and contact about being involved. Another key piece, sort of based on my experience, or that I suggest, is to start out with just a brief introductory email. So who you are, what you're looking for, but then it's really important to connect personally, either by phone or video, so that you can explain things further and make that sort of interpersonal connection to show that you value and are interested in engaging with the partners. And this should come from the PI, again, to convey sort of the value and importance in these relationships. So we developed in our project 5 evidence-based videos, each of which mapped on to a particular key message from a research study that we had conducted. This is just some screenshots of what the website looks like. So at the end of each of the video then has links to a blog post that describes in lay language more details of the research study, and it also has a link to the actual research study. You can see that there are also links to additional postpartum sexuality resources, blog, as I mentioned, and then the results of the studies. In terms of our dissemination plan, we had a public launch that was live streamed here in Halifax. You can see sort of some of the posters that we developed around that. We did a number of press releases and media interviews. We sent pitch letters with social media images to parenting websites, influencers, and various organizations. Our partnership with Reproductive Care Nova Scotia involved them putting little business cards with the link to the videos and the websites and all of their care packets that went out to new parents across the province. And we also did a series of targeted paid advertisements with via Facebook and YouTube. So our evaluation was developed based on some of the prior questionnaires of similar knowledge translation campaigns, and again, feedback from our advisory group in terms of how we were gonna, what kind of data we wanted to collect. So it was broken down into 2 pieces. We had the video reach, like analytics, and the effectiveness of the videos through self-report surveys, a parent survey, and a healthcare provider survey. The effectiveness of the videos was assessed via some evidence-based implementation outcomes that include looking at acceptability and appropriateness, which is things like whether they like the videos and their relevance, adoption, sort of intentions to share the videos or use them in their practice, penetration, which are things like perceived attitude change in some way. So I'm just going to give you a snapshot of a couple of these results. So the video reach was good. It was over 100,000 views during the sort of our active period of the videos were also pretty well liked by both parents and healthcare providers, with means around 4 and 5. They also saw them as relevant to the work they were doing, similar, high means there for both groups. And we had a couple of sort of pre-post type of questions, just keeping in mind that the surveys were completed at one time point. So these aren't true sort of examples of evidence of change, but oh, sorry, that's the next slide. This piece here is about adoption. So how likely or interested are you in learning more? So this was to us really an indicator that we were increasing awareness about the topic and interest in learning more about it. The pre-posting that I just started talking about is an example here. So how confident do you feel talking about your sex life after having a baby with your partner? We saw a significant increase with the medium effect size. But like I was saying, these are more a reflection of perceived change in attitudes because it wasn't actually 2 surveys before and after watching the video. So those are just a couple of the examples, but to summarize, we also had some qualitative data that showed similar kinds of things, that generally the videos were an acceptable and effective way of sharing knowledge about sexuality and the transition to parenthood. They did stimulate awareness and interest and some intentions to communicate more about sex. And if you're interested, the more of the details of these results have been published. The general idea was that we would add videos to the series as new research findings came out. So these are the most recent ones over the last year. And I wanted to mention that video 7, in particular, pain during sex, this was a response to the feedback from the surveys where people really indicated that what they felt was missing was a focus on pain during sex as something that happens in the postpartum period. And number 8 was also in direct response to the feedback we got from people around wanting to know just a bit more about what they could do differently and how to help them feel more prepared. So we did a video, again, evidence-based on sexual communication so that people could learn sort of some of the tips of how to talk to their partner about these issues. So I thought I'd just show one example of the video now. So this is the pain during sex video. We had these cute sort of gender neutral and racially neutral characters that go throughout the series.
Maybe you're pregnant, maybe you just had a baby. Either way, your body's changing in more ways than one. But you probably weren't expecting sex to be painful. You might be wondering how long the pain will last, and you're not alone. Our study followed 582 people from mid-pregnancy to 2 years postpartum. Pain during sex was common. And for most people, the pain peaked at 3 months postpartum, then steadily decreased from there. But we also found 2 distinct groups for pain during sex. While 79% experienced little pain, 21% experienced fairly significant pain. That's 1 in 5 people. You might be wondering if things like prior chronic breastfeeding affect the pain. The good news is, none of these biomedical factors seem to play a role, but we did find one key thing to look out for. Those who reported a lot of negative thoughts and feelings about pain, something called pain catastrophizing, were more likely to experience moderate and persistent pain during sex. If this sounds familiar, talk with your healthcare professional, as there are proven ways to help, including cognitive behavioral therapy, pelvic floor physical therapy, and topical medications. You're already handling a lot of changes by adding a baby to your family. It's common for your sex life to change after having a baby, but it doesn't have to be painful.
So that gives you a sense of what the videos are like. Oops, there we go. Okay. Just a couple more final considerations around partnership. So I've alluded to this already, but I think that it's really important to acknowledge the value added of each of your partners. So you want to pay your public partners or your patient partners honorariums. And you can also consider ways that you can make the relationship reciprocal. So ask what you might be able to offer in return. So as one example, with the parenting blogger, social media expert, I offered to write some guest posts to share on her that she could share on her blog, and also that we could post and share her blogs on our social networks as well. Second tip is around meeting as a larger group. So a lot of this work was pre-pandemic, where it was just so valuable to get the whole team together around the table to get more in-depth feedback from everyone and establish some agreement and pathway forward. So even things like looking at the scripts of the videos, really bouncing off each other and receiving all that input was super useful together rather than in sort of little separate meetings. And the last piece, which is really important, is to follow up regularly with updates with all your partners. So after you receive your input, it's really important to continue to follow up and share updates and engage your partners. You don't want them to feel like you sort of got what you needed from them and now they'll never hear from you again. So I essentially just put little like reminders in my calendar about when I was sort of due for checking in with all of our partnerships, give them updates on where we were with the project and when they could next expect to hear from us. And yeah, just consistently kind of investing and updating everyone on where we were at. So to wrap things up, we did see a positive response to our hashtag #PostBabyHankyPanky campaign, suggesting that it effectively raised that awareness and interest in target audiences. I hope you got sort of the message that the successful kind of KT approach that we took takes some careful planning, and it needs partnerships to ensure that it's meaningful to your target audience and that you're actually going to reach your target audience with your program. We appreciate your listening today, and I'm happy to answer questions and look forward to discussing this with everyone else in the group as well.
Thank you so much, Dr. Rosen. And as Sheila and Janice rejoin us, I can just pick up on a few ideas that came through in both of your presentations in terms of engaging with service providers, but also other members of the public or policymakers in your research, including the creation of formal structures in order to do so, such as the advisory boards or a working group, the importance of using your own network, but also the personal touch when reaching out to potential collaborators, and then these crucial ideas about recognition, both of the expertise that others bring, but also in terms of honorarium, and then also reciprocity and the need to engage, to make it meaningful, to engage over a longer period of time. For all of the attendees, I would really welcome your questions in the chat, but I will begin with one of my own, and that is, when you think as a researcher for Janice and Natalie, and then Sheila, when you put on your service provider hat and think about what has been the biggest reward, really, either of engaging in research or of engaging with service providers, what would that be for you?
Did you want me to start?
Sure, go ahead.
Okay. Biggest reward. Well, I mean, increasingly, my research has, focused on working with Sheila and the Ontario network, but I have done other types of research over time as well. And I'm thinking about one research program particularly, which focused on analyzing large data sets. So I'm going to date myself, the Violence Against Women survey, but also several cycles of the General Social Survey on Victimization, which includes a lot of information about sexual assault and intimate partner violence. And those surveys are powerful because they're population-based. They include a lot of people, but it's very, very difficult to take that work and affect change. Sometimes it's picked up. We had the good fortune once that I went into looking at some of that data with somebody from PHAC who was a policymaker, so it had more sort of direct implications on where they put some of their work later, emphasis on their work later that they wanted to do. But what's so rewarding about this type of work, this IKT process, and then in particular working with service providers and then other knowledge users, is if you've got the right people at the table from the start, it's much, much, much easier and more impactful and more rewarding for everyone, you know, to see it actually result in some kind of concrete change in policy or practice. So that's what I like about the work and find rewarding, is that you can actually see change. We didn't talk about our HIV PEP study, but it predated drug facilitated sexual assault. It was a huge study. But what we were able to do, without giving all the details, is in the end, we were able to take it back to the government and policymakers, et cetera, who we sort of engaged along the way, and show our successful findings and get ongoing kind of permanent funding for the program of care we developed as part of the research. So it can be impactful, and that's what I like.
Yes, I'm seeing a question actually about sustainability. So we'll come back to that. Perhaps, Natalie, you'd like to weigh in about what has been the biggest benefit or most rewarding from your perspective.
Sure. Yeah. I mean, this was almost a transformative experience for me as an academic, to where we have a tendency to do our research and to publish it and put it into journal articles and then move on to kind of the next project. And for me, I was junior in my career when I started this, and I just didn't want my career to look like that. I wanted it to also be about taking the research and figuring out how to make it more accessible, how to, especially when I do work on sex, like how to destigmatize it and open lines of communication, and figure out ways where the general public would also be engaged and understand and want to hear about the work we're doing. And I would say I would never go back. Like, I think that's really, and now it makes me think every project from the start. And that's the mistake I did with this one, is that I did it after the research was done. Whereas now I think much more about these things when I'm writing the grant proposals and before the project starts, and engaging the advisory board right from the start, which is also, the path that CIHR for sure is expecting as well. But it's been somewhat of a shift over the last number of years to have that expectation. So I have found it really rewarding to feel also like I'm meeting a need, because when we got the feedback from people on the videos, it was like, yeah, we don't have any resources around this topic. Thanks for doing this work, and now I have something to sort of point people to, or to open that communication. So that I really appreciate that piece of it as well.
Thanks, Natalie. Sheila, would you like to weigh in, wearing that service provider hat, what's been most rewarding for you?
From the clinician perspective, so our clinicians who are available 24 hours a day, seeing people after a sexual assault or intimate partner violence experience, so at difficult times, and can identify a challenge, an issue, what are we going to do about it? And then to be able to, so we want to do the best we can do with the evidence available to provide the best care for patients. So being able to identify and bring forward an issue or a concern to somebody like Janice, who shares our commitment in providing the best care possible. So we know what the issue is, but the research skills, specialized skills, how to design a study, the methodology, the interpretation, all that sort of stuff, to have a strong outcome, because ultimately affects the funding. Janice had mentioned around the sustainability of our HIV PEP program of care. Same with the drug facilitated. It affects then the funding for our programs and the sustainability of the outcomes of it. So collaborating and strong research does affect the quality of the care that we want to provide to the clients. And that's a commitment that I think all of us share. So it's been a huge benefit over the years to have this partnership. And the second is to engage with researchers who hear what the frontline clinicians are saying, because as a study is being designed, et cetera, it has to work on the front line if it's the clinician we're engaging with. So a study that's not practical, it's not feasible, it's not going to work, then being able to design it so it does work, that helps increase the engagement of the clinicians in the research.
So really clear again, the issue of relevance for the real world, both of the research and of the intervention itself for service providers, but also the people who they work with. I just want to give, because it's come in, the ability to mobilize policymakers and for funding and for sustainability of programs in the longer term. That's come up as a question as well. Would Janice or Natalie, would either of you like to make any, or Sheila, make any additional comments of that, about how engagement of service providers has supported sustainability of programs that are based on research?
I
mean,
yeah, go ahead, Natalie. Go ahead, Natalie.
Okay. I think it's like absolutely essential from my perspective, because the service providers are the ones who are in the best position to bring this topic in this context up with new parents. We know there's lots of research that says that new parents or just in sexuality in general, that patients are less likely to bring it up. And then the doctors think, well, if it's important, the patient's going to bring it up. And essentially you end up in the situation that nobody brings up or talks about sex because they're waiting for the other person. So in my field, like having buy-in from the service providers and from clinicians to say, yes, this is our responsibility and we're going to take it on to ask these questions and to bring up this topic is absolutely essential. So when they've been a part of it from the start, a handful of people even, then they have the enthusiasm and the motivation to champion it with others. They become the champions with the rest of their networks. And so that's a really key piece.
Janice.
Well, no, I was just going to say, Sheila, we both talked about it a bit already, like in terms of developing programs of care or interventions, and then, implementing, evaluating them, taking the findings to policymakers. We've been quite successful in, sustainability and ongoing funding being provided to those. But, it really depends on the research. In terms of the latter research I was talking about, the, TransLink network, there you don't have, we're working with like hundreds of community organizations and SADVTCs across the province. It's totally tied to grant funding. It's coordinated kind of centrally through the grant funding, through myself and Sheila as the principal kind of knowledge user on that particular project. But of course, we're looking to the future going, how do we maintain this? Who has the interest in the leadership? Sheila and I don't want the leadership of this. We don't even think it's appropriate to have the leadership of it ultimately. So part of the work that we've done in sort of the initial evaluations of the network, I shared some of that, is also, asking the partners who's interested in the longer term and maybe taking the leadership for this. And there are LGBTQ2S+ organizations for sure that, have indicated that they are. So that's good. But yeah, you've got to constantly kind of be thinking, if you're kind of grant dependent initially, on if this is good work and this work is successful and this work is helping, how are we going to sustain it over the long term?
Great point, Janice. Sheila, did you have anything additional to add?
I think one thing I would just quickly add is that, in Ontario, our network, we're working with programs across the province and need to consider all the different perspectives on the clinical level as we do our work, and with the results and what we're advocating for after. So, being able to have the evidence in hand of research we did with our clients and to go to our hospital leadership to say, this is why we need this, or this is why we need the funding from our funder. It adds a lot of strength to the sustainability of services when we can say, this is what we did. And when people can see, oh yeah, there is evidence, this is important for patients, etc., then it's much easier to have that longer term, because sometimes research happens was a great study, but it doesn't go anywhere, and there's no sort of continued program of care or service or impact, etc. So I'm happy that the work we've done, all the initiatives have been sustained for quite some time now. So it's been very beneficial.
Janice, you're really anticipating questions as they come up. So we have talked about the benefits, and I was convinced before we came into this conversation, but we really see the benefits of engaging with service providers from your experience. And so, Janice, you started to anticipate some of the organizational or management challenges that might arise, particularly around succession planning and sustainability. But I'd like to ask the full panel the question more broadly. What have been the management and organizational challenges of trying to use knowledge to transform practice? And of course, what have been, if any, solutions that you have tried to apply to those challenges?
I'm happy to add a little bit more to that. So I did have that, second to last slide that sort of talked about the challenges and the lessons learned and some of the strategies. But when I really reflect on some of those things in that kind of chart that we created, I think personally the biggest challenge kind of overall, and in particular related to the more recent work with trans communities and all the community organizations, as well as the SADVTCs, is changes in leadership. You almost need a full-time person on your team to keep up to date on who your connection is. And it's typically, I'd say, within our TransLink network, it is the executive director, or sometimes it's being delegated to somebody who does education or outreach. But there's a lot of changes in leadership in the community, and it's really important to stay on top of those, to have some mechanisms to onboard new folks, because they may know nothing about the history. You might have a long, really wonderful history working with a particular organization, and the leadership changes, and honestly, it can be back to square one again, building the relationship slowly. There needs to be trust. There needs to be a sense that you value each other, all of those things. And it can really take time. But we found the same thing with government decision makers and policymakers. Sheila and I have been very fortunate to be able to integrate from federal government and from provincial government over time, policy folks, into the research processes. And again, you just develop a really wonderful kind of working relationship where you're on the same page, you have the same goals and vision. You might be working from different ends of the sort of continuum to achieve those. And then suddenly they're gone. There's a lot of, I've learned over time, a lot of lateral kind of change within government, federal and provincial. So they were at wage, but now suddenly they're at health, or they're in justice. Which I think is great for the person themselves in terms of their learning. But again, you're starting over, on a particular project with the person, that you started out with, which maybe was working within PHAC or something. So those things are challenging, and it's just part of the work, and it can make things slower than you like sometimes, but it is what it is. And trying to have mechanisms in place with, frequent follow-up, with onboarding folks personally and things like that are really important.
Thanks for that insight, Janice. And we also hope that engagement, as people move either as service providers or executive directors of community organizations or within government, make those lateral or ascension moves, that they've learned something and have been changed through the relationship. So while not direct and while a challenge for that project, we hope that those benefits go on.
Well, and sometimes we bring them in. They're in a new department or they're in a new community org, and we reach out and say, well, do you want to bring your new organization you're leading into the network or the research? So yeah, it can work out. It can work out well in many ways as well.
Natalie, would you like to comment on this?
I think like with the type of work that I shared with you today, one of the sort of big challenges is figuring out what expertise or knowledge you don't have, right? So just because I use social media doesn't mean I know how to run a social media campaign or maximize it the way that like, or use it in a way that will be most impactful. So I think that was like a lot of learning to figure out, to find the right people who could had the expertise to learn for them, and then to figure out how to implement the recommendations to be most successful. So that comes back to sort of that planning tool, but also sometimes it just is a bit of a learning process to figure out what you know and what you don't know with this type of knowledge translation kind of campaign. So I would say that was a piece of it. And then the other piece that was a bit challenging, or that we kind of had to work on, was it's easy to engage people who are already motivated and enthusiastic about the topic. It's harder to figure out how to engage others, those who might not be already talking. Like, I didn't want all the people on my advisory board, all the physicians in particular, already asking questions about sex because they're the ones who are already doing it, right? So how to also approach and develop a relationship with people who with providers in our case who weren't asking those questions, who might have some of that discomfort, and then getting them sort of involved. And when we have success with that, then they become converted, right? And then they become the champions, like in their self-efficacy, their confidence in their ability to do it goes up, and that's sort of a win all around as well. So thinking about when you're putting together your team, like who has the knowledge, who has the expertise, who's already excited and invested, and then who's like missing, right? Who might be the people who are missing also from around the table, and how do we approach them too?
Really excellent point. Thank you. Sheila, did you have anything to add on this?
I'll just quickly say something that does impact is what's going on in the system at the time. If it's doing research or implementing program of change, for example, with COVID, organizations obviously had priorities around patient care related to that issue. Healthcare staff are redeployed. So sometimes you have to look at the timing of what's happening right now and whether this is the best time to bring forward. So I would just throw that in. You have to look at the big picture.
That provides a great segue in terms of looking at the big picture. I would like to invite Parliamentary Secretary Jenna Sudds, if you have any final reflections that you'd like to share with us.
Thank you. Thank you. I've got copious notes here. What a fabulous conversation. Thank you all, first of all, for the incredible work and research that you're undertaking, but also for this forum today to be able to share with others so that we can all learn from your experiences and best practices. There's so much to summarize here, but, maybe of a recent comment from Janice around, the challenges, but the benefits of integrating policy folks from our federal public service into the work that you're doing, despite its challenges, just the value of doing that. And obviously that's music to my ears, and hopefully a challenge that we can continue to make progress on. So that those can be fruitful longer term relationships. Another takeaway for me really is just the importance of not only the work you're doing, but ensuring that all of us, including federal governments, continue to work to increase the relevance of what you're doing and tying it to the positive health outcomes that you see. So much I could say, but I know we're running up against time, but just really grateful for this opportunity to join you, to be a fly on the wall, to take back some of your learnings and experiences. And thank you for facilitating this very important discussion today.
Thank you so much for joining us, and also my warm thanks, of course, to Natalie, to Sheila, and to Janice, and to everyone who joined us online as well. I would encourage you to come back and have another discussion with us on January 26th, which will actually focus on women's health researchers doing work that benefits women, trans, and non-binary people, and how they have successfully engaged with policymakers at the municipal, provincial, and federal levels. So more to come on that very important topic as well. And also encourage everyone to check out the POWER website where this video will be available, as well as to learn more about POWER and to sign up for our mailing list so that we can be in contact with you. Thank you, everyone, so much for joining this afternoon. And it was a great pleasure to have this very informative discussion with you. Thank you.
Thanks for the opportunity.
Thank you very much.